I'd like to welcome everyone this evening to a very important program dealing with the opiate addiction crisis that we're facing in this country. I'm very pleased to say that the Elks and Rotary International are linking their efforts to bring educational programs, improve awareness, assist our communities in increasing access to services, and finally trying to reduce the stigma with this horrible disease. We lost 72,000 Americans last year to this opiate crisis. And tonight, we are hoping that we can increase the awareness of our community, of our schools, of our law enforcement, and others that are trying to address this horrendous crisis in our country. Today, we're so fortunate to have two very special guests to begin with. Sarah Howroyd, MSW, co-founder of Manchester, Connecticut Hope Initiative, which is now, as I understand it, and we're going to learn a little more, has been expanded to 5 other police departments in Connecticut. And with her today is Marc Montminy, Manchester Police Chief, who partnered with Sarah, listened to the idea, and actually made this program possible, brought it to reality in our community in Manchester, Connecticut. And without more ado, I'd like everyone to please welcome these very talented, important speakers. Thank you.
Hi, everyone. Can you hear me? I think the mic has checked out well. So it's a genuine honor to be here tonight in my hometown. I grew up in Manchester, and I presently reside in West Hartford. But I was a third-generation Manchester resident. And I was a product of St. James School and Manchester High School. I was a straight-A student. I was involved in homecoming and blood drives and on student council. And I spent my Sunday afternoons volunteering to teach special needs kids how to swim, and my study halls in unified sports rooms because I didn't want to skip study hall type of deal. I had a really awesome childhood in Manchester. I was the product of 2 educators who both gave me more than is imaginable, and there was never anything that I could even kind of complain about with my upbringing. I was very blessed. I grew up in a Brady Bunch neighborhood off of Porter Street in Manchester. And then I went to college in Boston at Wheelock College in 2000, and I majored in social work, which I'm still a social worker today. But the rest of the story kind of decided the path within social work that my life went to. So I met someone when I was at Wheelock who was an engineer at Wentworth and had 3 degrees in engineering, and we fell in love and we spent all of our 20s together. And my dad was diagnosed with cancer in 2005, and so we were living in Boston and came home to Manchester because we just wanted to, offer support to my family. So we decided to go to Home Depot because we were going to redo my parents' kitchen because I was such a mess that I couldn't sleep, so we were going to repaint it. And in front of Adams Mill, a car behind me going 55, or a truck, a car in front of me slammed on their brakes. The car behind me didn't even hit their brakes and careened into us going 55 miles an hour without any brakes. Now, I went home that night. I didn't stay in the hospital. I had whiplash. I was sore. But in retrospect, the appropriate treatment intervention shouldn't have been 120 milligrams of OxyContin for both of us. And actually, I think for him, it was even a little more. Within a couple of years, we were doing heroin. Within a couple of years, both of our careers were in shambles. And I've really had to walk through the depths of hell to get my life back on track. But I'm so grateful that I have done so. And it's really been the support of my community and the support of the town of Manchester and people like Chief Montminy who were willing to take a chance on someone who was suffering from a stigmatized, very misunderstood disease that really has made me into the person I am on top of my parents. So I've been sober for going on 6 years now. And, oh, thank you. And I got my master's of social work, and I actually did my clinical hours at the Manchester Police Department on the HOPE initiative. And Chief Montminy and I had this amazing working rapport together, and I really look up to him. But it hasn't been easy. We started this process, and he's going to get into more detail about our HOPE initiative. But the last couple of years haven't been easy for me. The person who I referenced at the beginning of the story passed away 2 years ago from a drug overdose at 35 years old out in Colorado. He died. Again, 3 degrees in engineering. This can happen to anyone at any time from any walk of life. Addiction is very much a disease. I was having this conversation prior to this program, and if OxyContin hadn't existed, I know with 100% certainty, I personally would not have become a heroin addict. It really, 9 out of 10 heroin users we know started with prescription drugs. And it really pulled the wool over a lot of people's eyes. But we're hoping that the next generations are going to have a healthy fear of prescription medications on top of other drugs as well. So anyways, I am living proof. I'm here to answer questions and provide support in any way that I can. And I'm going to give Chief Montminy the microphone to start talking about our HOPE initiative. Thank you.
Thank you. So first, some statistics. Why is this happening now? Well, one of the reasons is because in this country we overprescribe pain medication to a tremendous degree. In 2012, 259 million prescriptions were written for opioids. Not 259 million pills, 259 million prescriptions. That's more than enough to give every American adult their own bottle of pills. The United States makes up 4.6% of the world's population, but consumes 80% of the world's opiates and 99% of one particular one called hydrocodone. That's enormous. It's clear that the U.S. uses more opiates to treat pain than any other country. Doctors in this country, dentists in this country have been taught to get ahead of the pain and that opiates are safe and effective. And it turns out that perhaps neither of those things are true. So, as far as why now, it turns out that if you're an alcohol abuser, you're 2 times more likely to become addicted to heroin. If you're a marijuana user, you're 3 times more likely. Cocaine, 15 times more likely. And opiate painkillers, you're 40 times more likely. So that's why. First off, we issue more painkillers than any other country, and you're 40 times more likely to become addicted to heroin if you abuse prescription opiates. So why is this happening now? Well, in large effect, it's happening now because of the fentanyl tainting our heroin supply. We're going to talk a little bit more about that later. In 1999, the number of overdose deaths involving opiates quadrupled. 2000 to 2015, more than 500,000 people died from drug overdoses. 91 Americans die every day from an opiate overdose. So, this is the aha moment. This is a map of the United States, a hotspot map. The darker purple is where the greater number of deaths are occurring in this country. This is in 1999. As you can see, in 1999, there were pockets of opiate deaths around the country that were alarming. Here's what the same map looked like in 2014. That's the aha moment, okay? Take a look at what's happened, and what I'm here to tell you is that this has gotten worse since 2014, not better. This is New England in 1999. Here's New England in 2014. For some reason, New England has a particular problem with opiates. We don't have methamphetamines here. Instead, we have opiate abuse. And it's rampant all throughout New England. So these are Connecticut's overdose death rates. And as you can see, in 2015, the red starts. The red is the introduction of fentanyl into the heroin supply. And what we found as a police department is that we arrested local drug dealers, and found out that they had no idea that there was fentanyl in their opiate supply. In other words, it was coming into the supply before it reached them. So people often ask me how this happens, and I'll explain it. If one gets a kilo of pure heroin, one adds 50% mix to it, binder or whatever you want to call it, something that makes it 2 kilos of 50% heroin, and they sell it. They double their profit. And then the person who has the 2 kilos does the same thing. They mix it with a filler, and now they've got 4 kilos of 25% heroin. Now, by the time it hits the street, it's 6 to 7% heroin. The rest of it's filler. But picture how many kilos you now have. Well, eventually, when the heroin drops to such a low quantity that it's not considered good anymore, you can literally sprinkle a little bit of fentanyl into the mix, and all of a sudden it's tremendous heroin again. So it allows them to step on it and make it more and more and more. So that's the reason that they add the fentanyl to the supply. Up until a year ago, fentanyl was available from China for $2,000 a kilo. A kilo of fentanyl is enough to kill everybody in this entire college. Fentanyl has no acceptable dose. In other words, in a hospital, they mix it in micrograms into an IV bag. That's how potent it is. If you were to snort enough fentanyl to fit on the top of a pin, it would kill you. The head of a pin, it would kill you. And so a kilo is enough to kill everybody in this college many times over. But it was only $2,000, so you could actually add a little bit of fentanyl to your heroin supply and increase your heroin supply. That's the reason they added the fentanyl to the mix. Here is what Manchester looked like. Manchester, a town of less than 60,000 population, since 2015, we've lost between 13 and 21 people a year. 2018 promises to be even worse than that. So, as law enforcement, this is an epidemic. This is a life safety issue. And here's what the deaths involving fentanyl look like alone. It's just incredible how it skyrocketed. There was a point in time when we used to send samples of heroin that we found to the state lab to have it tested for fentanyl. And they called us and said, stop sending us samples. And I said, well, what do you mean? They said, it's all got fentanyl in it. Don't even bother sending the sample. We know what's in it. So what happened was Sarah came to see me. Sarah and I had a mutual acquaintance, and she asked to talk to me about the opiate epidemic. And I agreed to meet with her. We sat down, and she said to me, what is the police department doing about this opiate epidemic? I said, well, we're the police department, and we arrest as many opiate addicts as we can, and as many drug dealers as we can. And she said, yeah, how's that working? Well, as you can see from the numbers, it isn't working. People continue to die, and if our goal is life safety, perhaps we need to do things differently. Those of you who are old enough might remember the original war on drugs. I believe it started during the Nixon administration. I know none of you are old enough to remember the Nixon administration, but you are. We got one person. We got one person. So that's when the war on drugs started. And the reality is we haven't really made much in the way of progress. And so I think what Sarah was trying to say is maybe we should take a different tact at this. So that's what we did. We sat down with people in the industry. We gathered, there must have been 30 people in the room. I had people from the hospitals, I had people from the methadone clinics, I had people from the recovery clubs, I had people from recovery organizations that did it for a living. And I had brought everybody into a room, and I needed to be educated as far as the opiate addiction cycle, just the cycle of addiction, and I learned a bunch of things I didn't know. As a police officer, for example, I didn't know that you're better off having no insurance than bad insurance. Didn't know that. I didn't know if you were on state aid that your treatment had to be in the state. So even if I can find you beds in another state for treatment, I can't send you there. If you're on Husky, you have to be treated here in the state. So I had to learn the industry, and one of the things I learned is not everybody needs to go to detox. I didn't know that. I assumed the first step in your treatment was you had to go through a week of hell in detox. You had to clean the heroin out of your system before you could go to a rehab. Turns out that's not always the case. So as we started to talk and learn and meet with people who were in the industry, we realized that we had the necessary resources right here in the town of Manchester to do better than just arrest bad guys and send them to jail. So we convened this working group. We looked at successes in other states, and some of you may be aware that this concept of police getting involved in the addiction, breaking the addiction cycle, actually started in Massachusetts. And so I called the town that it started in, and I asked them how they did it, and I realized that some of what they did couldn't be repeated, but other things could. And so we started to develop a framework of how we might assist people, and we involved key players. And those key players consisted of ECHN, for those of you who don't know, that's Manchester Hospital, it's Eastern Connecticut Health Network. We invited CHR. CHR stands for Community Health Resources. We invited Hartford Dispensary, which is a local methadone clinic, and we invited Pathfinders, which is a local recovery club. And what I didn't realize is that all of these people brought different experiences to the table, and I needed all of them. Here's what we concluded. The police need to adopt a new philosophy regarding addicted people. Police tend to be very conservative in their thinking, and they tend to think that addiction is a moral failing. And that's all fine and good, but while you're busy with your moral indignation, people are dying, and that's what we're trying to stop. The necessary resources were already available in Manchester, and we could help people more by working together than doing our own separate thing, and that's kind of what we decided. So the police are going to become the entry point into recovery rather than the entry point into the criminal justice system, because we know that bringing people through the criminal justice system simply does not work. And so we're going to try a new tact. So we reached out to the state's attorney's office, and we explained to them what we intended to do. And they said to us, basically, are we going to get more customers or less? And I said, you're going to get less. And he said, okay, go ahead. They were fine with that. So here's what Manchester Hope ended up looking like. The police deal with addicted people whether we like it or not. In other words, we know who our addicted population is. We know who our heroin addicts are. We deal with them on a regular basis. So our job is going to be to make contact with these individuals and offer them a different road. We're going to either we're going to bring the patient to the ER. The ER has agreed to take everybody we bring, and they're going to play the role of clinical gatekeeper. So their job is going to be to take in the patient, determine what the best course of treatment is for the patient, and make it happen. The hospital will likely either put the person on something called medication-assisted treatment, or if the person needs detox and inpatient treatment, they will arrange for that. And then we came up with the concept of recovery coaches to place in the ER. So for those of you who maybe aren't familiar with the recovery coach concept, this is an individual who's paid to be at the ER, who's paid to assist addicts trying to go through the recovery process, and most of these individuals are people in recovery themselves. So they know what this is about. You can't pull the wool over their eyes. They've been there, they've done that, and they can help you make it through. So our core participants were these, and the big one is ECHN. You need a partner health organization to play the role of clinical gatekeeper. It doesn't work any other way. You don't want police officers or any other untrained individual playing the role of clinical gatekeeper. Manchester's Human Services Department said that they would help out if an individual was homeless, if an individual needed access to Husky services or some other aid, the town of Manchester's Human Services would do that for us. CHR is an organization in town that deals with mental health issues, and they also have an addiction component. So if somebody has a dual diagnosis, we could utilize CHR. CCAR is the Connecticut Community for Addiction Recovery, and they are the ones that provided us with the recovery coaches. Then we had Hartford Dispensary, which is a methadone clinic, and UConn saw what we were trying to do and offered us support with regard to interns, and also they had an interest in evaluating the efficacy of this program to see how well it worked. So those were our core components, and I can't say enough about what ECHN brought to the table, but basically what it boils down to is we needed an addictionologist, someone who was an addiction expert who would work with us to determine what the best path was. And what we found is for many of these individuals who have absolutely no resources, the chances of them going to a full-time inpatient treatment program for 30 or 60 days is almost zero. I mean, some of these programs cost, Sarah, what, $5,000 a week, you know, or more. And the reality, 12,000?
That was the lowest.
12,000 a month was the lowest we could find. And the fact of the matter is very few of these individuals are going to have resources to do that. By the time they come to our door, the resources are over and done with. So here, we talked about that. We talked about, here is the police department's change. And this might sound like a very simple change, but this is a massive change in culture for us. What we're going to do is we're going to tell any person who comes to the police department and requests assistance, they will not be arrested for possession of drugs or paraphernalia. So if they come to us and say, I'm a heroin addict, I need help, you'll get them help. And what that means is you'll make them safe, you'll take them over to the hospital, you'll bring them into the hospital and get them started on the HOPE program treatment. The hospital agreed that they would have a new intake code called HOPE, and whenever somebody came in, they would know that they were one of our patients. They actually created a logo, which we thought was kind of nice. On the patient's chart, it had an H with a halo over it, and that meant the patient was a HOPE program participant. So anybody who comes to our doors and asks for that help will get it. But in addition to that, any person who you come across on the street who's in need of the HOPE program, the officers have the authority to put that person into the HOPE program rather than arresting him for mere possession. So I know that this sounds like a very minor thing, but this is huge for law enforcement. And what we're trying to convince officers is to be the pathway to recovery rather than the pathway to the criminal justice system, only because we know that the criminal justice system doesn't work. So we even created business cards. We made up business cards, and on one side it says, had enough? On the other side it says, when you have, give us a call, because you know that sometimes when you come into contact with an opiate-addicted person, that won't be the right time. That won't be the moment when they decide they need help. And so we give them the card, and we've found the card in the pockets of people, weeks and months later, who just didn't make the call, but were planning to. So these are the kind of changes that we made to the police department. And we started the program, I think the program officially started in December 2016. December of 2016, we kicked off the program right at the end of the month. So we had the full year of 2017. And at the end of the year, we had probably 25 people who had come through the system. Some had come through the system a couple of times because, I hate to say it, but that's one of the things we learned. I thought, find addict, deposit into the system, person's cured. Turns out doesn't really work that way. So some people had gone through the system several times, and because we're a police department and we're not HIPAA compliant, we don't keep records beyond who the person was, name, address, date of birth, but we don't have any records on how well the treatment went and if they were successful or what the treatment path was for them. So we don't know if we helped people or we didn't help people, except when people come back. So about a year and a week after we started the program, we got a phone call from our first patient, and he asked us to come to a local restaurant where they were having a party, and he was going to be receiving his 1-year chip for 1 year clean and sober. So we've now had 2 or 3 people who have called us and told us that they've been clean and sober for a certain amount of time, and to me, that's enough. That's enough for me. That's all I need to say, all I need to do to know that this is working. And so our next step was to try to replicate this program to other police departments. And we found that not all police departments are interested. What we found when we started to try to push this out to other police departments is there are some towns in Connecticut that don't have a problem. And so I remember having a conversation with one particular chief and said, you had 8 people died last year from your town. He goes, no. I said, yeah, I'm looking at the medical examiner's reports right now. He goes, no, look closely. You'll see that they died in Manchester. So I looked again. I said, no, they died at Manchester Hospital. They live in your town. He goes, they died in Manchester Hospital. And I said, okay, well, I mean, it's not my job to convince them otherwise, but I think that's kind of narrow thinking. The reality was there were people who died from surrounding towns who just didn't want to know. So I made it my focus to try to convince others that we needed to do more. We provided training. We provided Narcan. Does everybody know what Narcan is? For those of you in the viewing audience, Narcan is an opiate reagent, and basically, if you are suffering from the impact of heroin and you give somebody Narcan, basically it reverses that process and you can save someone's life that way. And so we had gotten almost 100 doses of Narcan for free. Now, Narcan costs between $75 and $100 a dose, and we got a case of it for free. And so we said, oh, this is great. What we're going to do is we're going to hand it out to anybody in the community who thinks they might need it, whether they have a problem themselves or maybe they've got a loved one with a problem. We're going to give you a $100 dose of this stuff for free. And we got a phone call from Consumer Protection who said, no, you're not. I said, what do you mean? He said, you can't give that out. I said, well, why not? He goes, because you're not a doctor or a pharmacist, and under state law, you can't give it to anybody. I said, well, it's harmless. And they said, yeah, we don't care. The fact of the matter is, if you're not a doctor or a pharmacist, you can't hand it out. So now we're sitting there with 100 doses of Narcan at $100 a piece that we can't use. So I called Consumer Protection and said, look, how can we do this? And they thought about it for a while, and they finally came up with a plan. They said, you know what? If you can get a doctor to give you a standing order, then you can hand it out. Just like a flu shot, basically. And so that's what we did. We got a doctor to give us a standing order, and then we were able to give out the Narcan to those people who needed it. We trained officers in the area. We had to train hospital staff, it turned out. So officers were told that they had to treat these people with dignity and respect. All right. And so they agreed to do that. And then we found out we had to tell the hospital staff the same thing. We had one individual, the police brought the individual, they walked them into a room, and a hospital staff member said, all right, I hope you're serious about this because this is going to take me a lot of time and effort. And of course, eventually the patient walks out. So what we got to do is, if we want them to be human beings, we have to treat them like human beings, and we have to be respectful. We also have an educational component, and this is the component that Sarah is particularly good at. Sarah goes into the schools and places where we were likely to find an audience and tells them about the addiction cycle and her trip through it. And she's very impactful when she talks, and so far, I believe we've done every high school student in Manchester, and we've taken our show on the road. And what I've been working on is trying to replicate this program elsewhere. And we've had some success. So as of right now, there are several towns who have started an opiate hope program. Enfield, Willimantic, Meriden, Berlin, and New Britain have all done the same thing. And basically, we're starting to use police officers the way they should be used to help stop this addiction problem and get people out of the courtrooms and into treatment. And we'd like to think we're successful, but this is why we developed this program, and this is why you're here today. At the back of the room, we left some flyers for Pathfinders, which is the local addiction club, and their schedule is back there. And I believe they also have these recovery as possible armbands back there, which you're welcome to take if you like. And what we'd like to do before we start our next speaker is see if anyone's got any questions for either of us. Dave, you're always good for a question.
How in the world did you get all of those groups to work together and change the community so that they were more responsive? It sounds like you increased awareness, which is clearly a goal, and we clearly want to thank Marc Montminy for your chairmanship of our Rotary Addiction Task Force and making such a difference, bringing these types of ideas into our Rotary community and into the larger community. But it sounds like it was awareness and education. It was increased access to services. And finally, you started to address the issue of reducing the stigma, which are the three priorities that came out of your task force, Marc, and we're very proud of your service.
Well, thank you for that. But the reality is the talent was already there. What we found was that they just lacked leadership. They were all doing their own thing, but there was no state or federal funding, and therefore there was no initiative. And by getting these people in the room together, and I have to say, it's a replicable process. We can replicate this elsewhere. So, for example, we took this show to Meriden, and we sat down with the people in Meriden, and they did the same thing. They brought in, what's the name of the hospital? Do you know the name of the hospital? Midstate? Midstate is in that area. Midstate came in, sat at the table, and we introduced ourselves, and the guy at the other end of the table is the president of Midstate. I said, oh, great. So we explained to them what we wanted to do. We explained to them that we're going to be dropping these people off at your door. It's going to be your responsibility to get them into treatment, and your clinicians are going to be responsible for deciding what treatment is appropriate. And he said, yep, I'm in. It was almost like everybody realizes that this problem is out there, and they're all willing to address it. Just nobody had put the pieces together. And so by putting the pieces together, we were able to get everybody to work. Yes?
Before you answer,
Oh.
before you ask, could you use the microphone so we can get it on tape?
My name's Henry, and my son passed away less than a mile from here on May 23rd of a fentanyl and cocaine overdose. And that's part of the reason why I'm here tonight. But I'm also here because I had some interactions with, the next day I went down to the police department, and I gotta tell you, here I went up to the front desk to see if I could get the police report. And they said, we'll go over to that window over there, and I started crying. And they said, sir, please sit down. We'll take care of this for you. They walked me into a room. Your Lieutenant Dunnigan came in, sat down with me, and talked to me. I mean, I'm a parent. This is part of what else is going on here too. Is there's a lot of collateral damage, and but I needed answers. So it turned out that the case had been sent up to one of the detectives. So he called me in, Detective Davis. And all I can say is that through this whole process, everyone at the Manchester Police Department has just been phenomenal with me. And we don't have resolution yet. And I turned over his electronics and things like that. And I don't even know if I care if, you find who did it, only other than maybe save somebody else from going through this. But I want to thank you personally for your department and for their efforts, because even the night he died over at Pascal Lane is where he passed away. And we were treated the whole process with respect and dignity, and I want to thank you very much.
Well, thank you. I'm glad you had that reaction. Very sorry for your loss, but I hope that that what you observed is what everybody else observes. You know, if we treat this like the disease process that it is, you know, people will think of it more like cancer and less like a moral failing.
And people like you are the exact reason why I stirred the pot and Chief and I have done this in 100% volunteer capacity, but it's families just like yours that we're doing this for.
I'm here tonight because of Facebook and you too, that's why too. I don't know if you were down at Purdue Pharmaceutical for the march down there, but.
I started a new job, so I couldn't make it, but I was there in spirit.
I was there.
I wanted to be there.
Very powerful.
Yeah. And I too am really sorry for your loss.
Tell them a little bit about the lawsuit.
Yes, so I've pushed the town of Manchester to to embark on the journey of suing Purdue as well. They're one of the 500 municipalities that are engaging in suing Purdue. There's also some work in the federal government that's talking about holding them liable criminally. I personally, my big push behind the civil penalties was hoping that criminal penalties for their executives would come out. It was never about the money. You know, no amount of money will bring back the lives that have been lost. But I think there needs to be serious, you know, consequences for what they sparked. And so, you know, the systems in place are set up to keep them in power, and so something needs to be done.
Yeah, I'm Jerry Gallo. I'm liaison from the Manchester Elks Lodge to the Hope Initiative, and I want to thank you both for allowing us to partner with the Manchester Rotary and bring the fundraiser last week and this event tonight. I was in basic training when President Kennedy was shot, so I remember the Nixon Initiative on the War on Drugs. And in 1997, I was at the Chicago Navy Pier with the Elks National Convention with General Barry McCavery, who was President Clinton's drug czar. Congratulated the Elks for being one of the only groups in the country still left talking to our kids, and talked about how the hope of winning the war on drugs was very possible. And I guess your graphs show how the drug addictions, for instance, 1997, have grown. So I guess I'm cautiously optimistic that this initiative will work, but I want to find out what you think the likelihood or the not likelihood of us having the 20th Hope Initiative fundraiser would be or not be. You know, is that, what's your thoughts on that?
Well, I think what you're asking is this epidemic going to be over in 20 years? And my thought was that I don't know if we can claim that it'll be over, but I'm hoping it's on the downward slide. And right now, I'm not even convinced it's on the downward slide. I got a feeling that 2018 stats are going to be even worse than 2017 stats. And I don't know that we're over the curve, but what I do think is by providing this level of education, we can certainly save, there's a generation that can be saved from falling into the same trap. And one of the things I want to make sure everybody knew is that this is not a young person's issue. So when people think of heroin addiction, they're often thinking of 18 to 25-year-olds. The average age of the people who have died in Manchester is 39. So this is not necessarily just in the young population. It's across all populations, including the elderly. And teenagers too. So we're hoping that we won't be here in 20 years, but we're not certain that we won't.
Hi, my name is Nadine Repenez, and I just wanted to offer an additional resource. I come from Clean Slate Centers. We are in Hartford. We are a Suboxone program and a medication-assisted treatment program. So we offer an additional resource in addition to ECHN, and we have open availability. We have no wait list. We have walk-in hours, and we have a program that works. So anyone that needs help, see me. I put some materials out there, and it does work. So that's all I wanted to say. Thank you.
Okay. We have other questions, or are we ready
Anybody
for
else?
our next speaker?
You know, I'd like to thank Mark. Thank you, Mark, for your service. You've made a real difference in the education, the awareness. You've brought services and access. You're a Rotarian in Manchester. We appreciate your service and for serving as chairperson of our addiction task force. We appreciate that. And Sarah, you are the lifeblood of the HOPE program. And I can't tell you how proud we are of you. Now, Mark already has this special pin called Making a Difference, you know, but you don't yet, and we're hoping that you'll join us in Rotary in the future. So please accept this as our thanks, and a big round of applause to these wonderful speakers. You've done a great job up here. We appreciate your service. And you are both making a difference for international, you know, the international community, actually. Thank you very much.
Thank you.
Okay. Hey, Dave.
Now.
I'd like to change batteries.